Well, hello. So today we are going to be thinking about calcium and phosphate homeostasis. And when you hear calcium, you have probably immediately thought about bones or even teeth. And whilst that is true, one of the major themes today is that calcium is actually regulated far more tightly because of its roles in nerve and muscle function rather than because of its structural components as part of bones, because a very small change in the plasma calcium can have major physiological consequences, which is why the body invests multiple hormone systems to try and keep it stable. And to do that, keep that stability, we have two major hormones that I want you to think about. So those are parathyroid hormone and vitamin D. And those two hormones work hand in hand to regulate calcium and phosphate homeostasis. And yes, I did just say that vitamin D is a hormone rather than technically a vitamin. It is made from cholesterol and it is technically a steroid hormone rather than a vitamin. So that's just to put that at ease or put it in your mind for now. So what are we thinking about here? Well, calcium, it's got a lot of different functions. It's a structural component of bones and teeth, and I've already said that. So 99% of our total calcium is stored within the bone. And even though 99% of it is stored in the bone, the body is primarily regulating the tiny fraction that is present in the extracellular fluid and in the plasma. And that, like I said earlier, is because that small fraction is the biologically important pool in neuromuscular function and cardiac function. So in terms of neuromuscular and cardiac function, of course, it's maintaining the normal excitability of nerve and muscle cells. It's involved in muscle contraction of your skeletal muscle and your cardiac muscle. It's involved in the activation of many enzymes and in the secretion of neurotransmitters and hormones. And so if you notice, most of the functions listed here are ongoing minute-to-minute functions. And that's why calcium concentrations have to be tightly regulated rather than simply reflect the dietary intake. And often students actually underestimate how dangerous abnormal calcium can be. Both severe hypocalcemia and severe hypercalcemia can actually be life-threatening. And as I've said, calcium levels within the blood are regulated primarily by two hormones, parathyroid hormone and vitamin D, and to a much lesser extent by calcitonin, though we will touch on it so you kind of know what it's involved in and what it's actually doing. So we've already said that 99% of calcium is found in the bone within and the skeleton. About 0.9% is intracellular, so inside your cells, and that's in primarily in the sarcoplasmic reticulum and the endoplasmic reticulum. And then you have a much lower amount in the extracellular fluid at around 2.1 to 2.6 millimoles per liter. And so when we take a look at that plasma calcium, and this plasma calcium obviously that is measured in a clinical scenario, about 50% of that is bound to protein, and that's primarily to albumin. And that is really important to understand in a minute, because we'll talk about how the levels of albumin actually alter the values or the amount of active calcium. So 50% is bound to protein, 40% is free and ionized and in its biologically active form. So that's the stuff that does the work, that does the job. And that is maintained at a constant level. And we've got another 10% or so that is bound to anions in soluble complexes. But a key thing is that actually, if the amount of albumin in the blood is low, that alters the amount of the free or biologically active form. And that is not, that could give abnormal results or make results look normal when they're not normal. So if we try and explain this a little bit better, when you order a calcium in the hospital, what you actually receive is a total calcium. Remember, only the ionized fraction or the free fraction is biologically active. So therefore, this is why albumin becomes important. If albumin changes, total calcium can change even when the ionized calcium remains completely normal. And in critically ill patients, ionized calcium may be measured directly because correction formulae, which you can see in this slide, start to become less reliable. And just so you've got a general indication, the corrected calcium is shown on the bottom left-hand side, And so that just tells you what most labs use to measure the corrected calcium, bearing in mind if someone had a low albumin level. So it's telling you, if you've got a low albumin level, we'll correct the calcium to make it look like what it would be if the albumin was actually normal. So how is that calcium regulation balanced? Well, it's regulated. Well, it depends on hormonal control. And we've talked about those hormones already, but it also depends on dietary intake. So in your diet, you take in about 1 gram per day. And I'm going to throw you some numbers around, okay? And I do not want you to think or even memorize these actual numbers. They're really unimportant in the great scheme of things. The important thing is that calcium is constantly moving between compartments. Okay, that's the key thing I want you to take back. So ignore the kind of numbers, but you take in about 1 gram of calcium every day into your gut. About 40% of that is absorbed and goes into your extracellular fluid, where you have a certain amount in total, so 20 millimoles. But like I said, don't worry too much about the values. You resorb about 8 millimoles from your bone, where most of it is stored, of course. And you also deposit the same amount together. So you're getting this continual bone turnover, but in health, you're not getting any weakening or strengthening of bone, presuming that you're at a normal, healthy level. We also excrete a small amount in our urine as well. And we also excrete some into our gastrointestinal fluids, which is then passed, some of it is then passed out through feces. So you can see there's this whole cycle going on where we're taking some in, we're resorbing our bone, but laying down our bone, and we're removing some through both feces and through urine. And it's important to realize that bone is not simply a storage depot. It's a dynamic tissue undergoing continuous deposition and resorption throughout life. So when we talk about parathyroid hormone in a few minutes, I want you to think of it as shifting calcium fluxes between these compartments. Okay, that's what I want you to think. This is what parathyroid hormone and vitamin D as well are involved in. They are regulating all of these processes that we've just shown on this slide. And it's also important for you to remember that plasma calcium is tiny compared with bone stores, so small shifts can have major clinical effects, and we've already touched on that. So I'm going to throw a review question in for you. It's not important to understand the clinical scenario as such, but I want you to just think about the principles that we've just covered. So press pause, read the question, come up with your answer. Only one of them is correct, and then I'll go through it. Okay, so a 62-year-old woman presents to her GP with fatigue and weight loss. Blood tests show a total calcium looking low and an albumin also looking low. Why is it important to calculate a corrected calcium concentration in this patient? Is it A, B, C, D, or E? Hopefully you've written B. A significant proportion of plasma calcium is bound to albumin. And that's because a large proportion of plasma calcium is bound to albumin. And when albumin levels are low, the total measured calcium may appear reduced even when the biologically active ionized calcium is normal. So the corrected calcium adjusts the total calcium to account for the abnormal albumin levels and provides a better estimate of the patient's true calcium status. And this is really important because it helps clinicians avoid incorrectly diagnosing hypocalcemia based on total calcium alone. So there's a really good reason that a corrected calcium is calculated. Okay, so we're going to have a little bit of a think about calcium regulation. Now, we often teach about 3 hormones, and I've got 3 hormones written there: parathyroid hormone, vitamin D, and calcitonin. But in reality, it's parathyroid hormone and vitamin D do most of the work. You can kind of think of calcitonin as an optional extra. Humans can function quite normally without significant calcitonin activity. So when we're thinking about the regulation of calcium levels and phosphate levels, we have to think about the bones because that's where 99% of our calcium is. So we have to think about the types of cells that are important for bone formation and bone resorption. So in your bone, you have osteoblasts. So the osteoblasts are synthesizing and secreting your collagen osteoid, and they are promoting the deposition of calcium phosphate crystals. So they're basically involved in laying down bone. just have in your back of your head as well, the osteoblasts, as they are laying down bones, release an enzyme, alkaline phosphatase, or ALP. So if you get a raised ALP coming from the bone, that's a sign that osteoblasts are doing some repairing of some kind, or laying down some bones. It's not always about repairing. You've also got the osteoclasts, and these osteoclasts release proteolytic enzymes and acid which help to break down the mineralized bone, and that leads to the resorption of the bone and the release of calcium and phosphate. So although the osteoclasts resorb bone, they're actually essential for healthy bone because old bone must be continually removed before new bone can be laid down. And a useful aid or memory aid to try and remember what osteoclasts and osteoblasts do is osteoclasts. So you've got the Cl, they clear Cl away bone, whereas osteoblasts, that's the B for blasts, they build the bone. So that's one way of thinking about what's actually happening there, if you struggle to remember which is which. And finally, you've got the osteocytes rather. Once surrounded by calcified matrix, the osteoblasts kind of turn into or become osteocytes, and they sense mechanical strain or bone strain, and they signal to the osteoblasts and to the osteoclasts to regulate bone remodeling. So those are the three main cell types that I want you to really have in your heads. Osteoblasts, they promote bone laying down, osteoclasts promote resorption, and the osteocytes are sensing mechanical strain and talking to the other two. So calcium regulation. This, I think, is probably the most important slide in this session. And if you only remember one thing from this slide, it's that parathyroid hormone raises plasma calcium levels. That's the key thing that it does. Okay, it does also reduce plasma phosphate levels, which is actually really important as well, but it increases plasma calcium levels. So it stimulates the osteoclast formation, so immature osteoclasts into mature osteoclasts and their activity, so releasing bone, calcium, and phosphate. It increases renal calcium and magnesium reabsorption, so we're increasing the amount of calcium and the phosphate that we're reabsorbing from the kidneys. And it decreases phosphate reabsorption, or another way to think of it is it increases kidney phosphate excretion. So it excretes phosphate out of the kidneys. Also really important, it activates vitamin D in the kidneys. So vitamin D, as you may well know, needs three systems to be working. We'll talk about it in a second, but it needs UVB. So UVB is the initial part. So you need skin and you need sunlight activating the cholesterol in that skin. It needs the liver because the next stage in vitamin D maturation takes place in the liver, and the final activation occurs in the kidneys under the auspices of parathyroid hormone. It is doing the activation in the kidneys themselves. Calcitonin, we will talk about it very briefly, okay, even though it's not particularly physiologically relevant in humans. It's secreted from the thyroid gland when calcium levels are elevated. So it does inhibit osteoclast activity, and it does increase renal excretion of calcium, so more calcium is lost. But it has a very, very minor role in humans, so I'm really not worried about it too much, and I don't want you to worry about it. It does have important roles, which we'll maybe touch upon a little bit later. So another review question for you. Okay, so again, I would like you to press pause, read through the question, and pick the correct answer, A, B, C, D, or E. Okay, so 68-year-old woman goes to a GP with a 3-month history of progressive muscle weakness and bone pain. Blood tests show a low plasma calcium and an elevated parathyroid hormone. Remembering, of course, PTH increases activation of vitamin D in the kidneys. Which physiological effect of vitamin D helps restore her plasma calcium levels? A, B, C, D, or E? Hopefully you have said it increases calcium absorption in the intestine, so that's option B, because active vitamin D increases intestinal absorption of calcium and phosphate, helping to restore calcium availability for plasma and bone mineralization. Okay, so vitamin D synthesis. Now, I've already kind of touched on this already, but we'll go through it because it helps to put it into nice context for you. So vitamin D synthesis requires UV light, so UVB specifically, normal liver function, and normal kidney function. Okay, so that explains, and when we've gone through it, you'll see why this pathway explains why both liver disease and kidney disease can contribute to calcium disorders. So we, on many students, focus on vitamin D deficiency due to a lack of sunlight or dietary intake, but clinically impaired activation in chronic kidney disease is often just as important, because in chronic kidney disease, remembering activation of vitamin D takes place in the kidneys, it's not going to be as efficient. Anyway, so what's happening? So cholesterol is converted to 7-dehydrocholesterol. Important thing, that is activated in the kidneys in the skin, to an early form of an inactive vitamin D3, so cholecalciferol. This is where most of your dietary intake of vitamin D comes. So vitamin D3 often comes in the form of diet at this stage. Then this becomes hydroxylated in the liver to form 25-hydroxycholecalciferol. This is often the form that is measured if you take a blood sample and you're looking for kind of how much vitamin D, how much precursor vitamin D is there in the blood. You'll measure the 25-hydroxycholecalciferol. And then that 25-hydroxycholecalciferol is activated via parathyroid hormone in the kidneys to the active form of vitamin D, which is also called calcitriol. Okay, so calcitriol is the active form of vitamin D. And vitamin D does a few things. So vitamin D keenly, or very importantly for us, it promotes intestinal absorption of calcium and phosphate. So it drives our gut to absorb the calcium we're taking in, but also the phosphate that we are taking in. It also promotes bone mineralizations. But interestingly, at very high concentrations, it stimulates bone resorption by the osteoclast. So it's kind of doing a couple of different things depending on its particular levels. And vitamin D, as you might expect, as it starts to build up, it starts to inhibit the enzyme 1-hydroxylase. So it's kind of just like in all the endocrine systems, we've got a negative feedback loop there trying to keep it in check. But how are calcium and phosphate regulated overall? So we're thinking, how do parathyroid hormone and vitamin D work with each other to bring total regulation of calcium and phosphate? So this slide is basically bringing together everything that we've already discussed. So try to think about what happens when calcium falls. Well, when calcium starts to get a bit low, the body detects this fall. And therefore, that low blood calcium is detected by the parathyroid gland, and parathyroid hormone levels rise. Now, parathyroid hormone does lots of things. It acts on the bone, and it starts to resorb both calcium and phosphate from that bone. So calcium and phosphate levels start to go up. And that increases both of those things, calcium and phosphate, as I've just said. It acts on the kidneys, and in the kidneys, it stimulates calcium reabsorption. So again, increasing our plasma calcium, but it also increases phosphate excretion. That's really key, okay? And finally, it activates vitamin D, and vitamin D acts on the small intestine to stimulate calcium and phosphate absorption. So overall, what we've got happening here is that a low calcium drives PTH release, drives activation of vitamin D, and altogether they increase calcium absorption, increasing our plasma calcium levels. But at the same time, phosphate is changing. The overall effect of PTH is to reduce phosphate levels. So even though we're absorbing more from the gut, we're resorbing more from the bone, we're excreting even more of it out of our kidneys. So overall, phosphate levels drop, calcium levels rise. And of course, there are negative feedback. As our calcium comes back to normal, has negative feedback on the parathyroid hormone, and likewise, vitamin D is also having a negative feedback on the parathyroid gland as well, again, reducing PTH levels. So you've got this whole cycle going on. So key Key point here is multiple organs are acting in a coordinated fashion to achieve a single goal, restoring our plasma calcium levels. Again, we have another question for you to think about. Please press pause, read the question, look through the options, and pick the most appropriate one. Okay, so a 65-year-old man goes to a GP with 2-week history of muscle cramps and fatigue. Blood tests show a low plasma calcium level. Which change in renal handling of calcium and phosphate is most likely to occur? So hopefully you have picked option C, increased calcium reabsorption and increased phosphate excretion. And hopefully you know why that's happening. You've got a low calcium, parathyroid hormone is released, that activates vitamin D, and therefore calcium and phosphate absorption in the gut happen. But in the kidneys, the PTH is causing calcium reabsorption and excreting phosphate levels. So now that we've covered the normal physiology, we can start to think about what happens when the systems fail. And we're really only doing this at a very, very basic and simple level. We're going to talk on hypocalcemia. And when approaching hypocalcemia, it's often helpful to think in terms of which organ system has failed. Is it the parathyroid gland? Is it the kidney? Is it the gut? Or is it the vitamin D pathway? All of these issues can lead to hypocalcemia. And so what I'd like you to do when you're considering causes, I want you to think, what are the potential causes of hypocalcemia and how do they relate to the parathyroid gland, to the kidney, and those other causes that we've just talked about? So just press pause. What causes of hypocalcemia can you think about that relate to the parathyroid gland, the kidneys, and to other, which could be many things, but we're just going to focus on the main ones. Okay, so the parathyroid gland. If you have hypoparathyroidism, you have inadequate PTH levels, which means reduced calcium conservation by the kidneys, reduced vitamin D activation, and reduced calcium mobilization from the bone. So there's hypoparathyroidism. For example, autoimmune causes. Chronic kidney disease. In chronic kidney disease, you have impaired calcitriol or vitamin D production and therefore phosphate retention, both of which disrupt calcium homeostasis. And that can lead into secondary hyperparathyroidism because your chronic kidney disease means you've got low calcium. So therefore the parathyroid gland responds and produces lots of PTH to try and compensate. So that's secondary hyperparathyroidism. What other causes could you think about? Hopefully you thought about vitamin D deficiency. If you have a vitamin D deficiency, and we've talked about some of those causes, you get reduced intestinal calcium absorption due to inadequate sunlight, malabsorption, liver or kidney disease. There are lots of causes. And that, of course, reduces your calcium level. Magnesium deficiency, this is an important one just to think about, in particular in hospital patients. Magnesium deficiency can impair both PTH synthesis, secretion, and its action. So it is important to understand. And if you're thinking about what happens in an ECG because of hypo and hypercalcemia, a classic is a hypercalcemia, which we'll talk about in a little bit. It shortens the QT interval, whereas hypocalcemia prolongs the QT interval. And it just increases the risk of cardiac arrhythmias. What are some of the symptoms? There are clinical features specific to hypocalcemia, and most of these symptoms are due to increased neuromuscular excitability, because calcium normally stabilizes voltage-gated sodium channels. When calcium levels falls, nerve and muscles become easier to activate, so you get increased neuromuscular activity, and this explains some of the typical symptoms of pins and needles, muscle cramps, and in tetany. And in severe cases, it can lead to seizures. So, hypocalcemia, that's all we need to touch on for that. Hypercalcemia is essentially the opposite physiological state. Instead of excessive excitability, cells become less excitable and patients often become lethargic, weak, and cognitively impaired. So, what are the causes you can think about? So, or you can think of. So again, press pause, think, what causes of hypercalcemia can you think of? Okay, so for exam purposes, this is actually really easy, and we all think about exams. You need to think about two major causes. One is primary hyperparathyroidism. So it might be a parathyroid hormone secreting adenoma, for example. The second, we put it down as bones, but really it's about malignancy. Okay, so malignancy, this can be through direct bone resorption by tumors, tumor activation of osteoclasts, or also the ectopic production of PTH-RP. That stands for related peptide, and is basically a shortened version of PTH that is secreted by some tumors that activates or works just like parathyroid hormone does. Because it allows certain cancers to mimic the actions of PTH. So really, what I want you to be thinking about is these are the main causes. You need to be thinking PTH secreting adenomas and then malignancy. Those are the two most common causes of hypocalcemia. There are others, but those are the ones I want you to think about. A useful exam clue for you is that malignancy-associated hypercalcemia usually suppresses native PTH secretion. So if you have a malignancy and you have hypercalcemia, if you measure the PTH, you would expect it to be low because you've got too much calcium already. So what about some of the symptoms of hypocalcemia? Well, it has the opposite effects to hypocalcemia, remember? So you've got increased extracellular calcium, makes action potentials harder to generate, resulting in reduced cellular excitability. And this can be broken down into mones, bones, groans, and stones. And we'll talk about it now. So in mones, you get decreased neural excitability. And because of that, you get confusion, lethargy, weakness, and depression occur because those neuronal and muscular activity is suppressed. You have groans. So abdominal symptoms are often related to reduced GI motility, leading to abdominal discomfort, nausea, and constipation. You've got stones. Excess filtered calcium increases the risk of calcium-containing renal stones. And likewise, your polyuria and polydipsia, hypercalcemia is a common cause of polyuria, and it reduces the kidney's ability to concentrate urine, producing a kind of nephrogenic diabetes insipidus-like picture, so excretion of large amounts of water. And that water loss then causes thirst and dehydration. And then you've got the additional feature of hyperparathyroidism, which is your bones. And in such conditions, increased bone resorption releases calcium into the circulation and more may cause bone pain and fractures because it's being lost from the bones. The key message, though, is simple. Low calcium increases excitability, whereas high calcium reduces excitability. So this slide is really asking you to apply physiology rather than recall facts. So, and instead of memorizing lab patterns, think through the effects of excess PTH. If PTH goes up, what should happen to calcium? What should happen to phosphate? Because once you understand those relationships, the lab findings become much easier to predict. So what I'd like you to do is have a look at these. So predict the changes in each case. Will PTH, calcium, phosphate, ALP, and calcitriol, so active vitamin D, go up, down, or stay the same? In primary hyperparathyroidism, so that is down to an adenoma or hyperplasia, for example, in the parathyroid gland. Secondary hyperparathyroidism, because of chronic kidney disease, or tertiary hyperparathyroidism. And tertiary hyperparathyroidism and secondary are down to that chronic kidney disease. But in secondary, it's an appropriate physiological response to chronic hypocalcemia. In tertiary hyperparathyroidism, that develops when long-standing stimulation causes the parathyroid glands to become autonomous and continue secreting PTH even when the calcium levels rise. Okay, and that tends to be more prominent as patients verge towards requiring dialysis. So secondary and tertiary in this case, we're thinking down to chronic kidney disease. You're linking things together. So press pause, work your way through each of these, up, down, or stay the same. Okay, so we're going to go through this, and I want you to just remember this is a generalization, okay? So not every set of results is going to be identical, but it gives you a principle to understand what's going on. So in primary hyperparathyroidism, obviously you've got an adenoma or hyperplasia, so PTH levels are high. If your PTH levels are high, your calcium levels are high because you're increasing bone turnover. You're increasing the amount of vitamin D and you're increasing calcium reabsorption through the kidneys. At the same time, you're increasing phosphate excretion, so phosphate goes down. Because you are turning over the bones more, you're resorbing bone, ALP goes up because you've got bone turnover, bone breaking down, but more bone being made. And vitamin D, again, that's likely to go up as well. So those are the kind of most likely changes in primary hyperparathyroidism. Now, in secondary hyperparathyroidism due to chronic kidney disease, what you've got to remember is the kidneys are not working properly. Okay, so they are not responding in a way that a healthy kidney would. So PTH levels go up. They are being driven up because the calcium levels are low. The kidneys cannot reabsorb as much calcium as they usually would because the kidneys aren't as responsive to PTH as they usually would be. Phosphate levels go up because the kidneys aren't as responsive to PTH, so the kidneys don't excrete as much phosphate, so phosphate levels start to rise. ALP levels go up because PTH is breaking down bone and regenerating bone, so therefore you've got this bone turnover. And vitamin D levels go down because obviously the kidneys aren't working effectively, so parathyroid activation of vitamin D in the kidneys is not working as well. And it's that drop in vitamin D causing that drop in calcium, triggering that PTH. That's that whole cycle going on. Now, what we've got in tertiary hyperparathyroidism is PTH being autonomous. So it's just gone a little bit ballistic. And now, because it's gone a little bit ballistic, what's happening is that the calcium levels are rising. So calcium is rising, even though we can't activate the vitamin D properly and we can't reabsorb in the kidneys, but we can break down loads and loads of bone. Okay, so we broke down lots of bone to increase that calcium level. Phosphate levels rise as well. We're breaking down lots and lots of bone, but we cannot excrete it through the kidneys. ALP is going up because we're breaking lots of bone, so we're making more bone as well. Okay, so the ALP levels go up and vitamin D levels obviously go down because the kidneys aren't working. So in autonomous, what you can see there, most of the pictures look the same, except that PTH is much higher and that now calcium levels, instead of being low, are verging back into the normal or the high end normal or even into the elevated level. So you can start to think about how things change when PTH secretion starts to become autonomous.